Hello everyone, I'm Dr. Samir Diliprane. I'm an associate professor in cardiology at UN Mehta, Ahmedabad. My topic for today is cardiac magnetic resonance imaging in cardiac implantable electronic devices. There is a high prevalence of cardiomyopathy and arrhythmia for which cardiac MRI has been shown to have particular diagnostic and prognostic utility. There is an increasing utilization of cardiac implantable electronic devices over the past decades, and it is estimated that 1 in 2 patients with CIEDs will require an MRI following a device implant. The magnetic field generated by the MR scanner has generated safety concerns, and there is an unmet need to establish informed decision making for CMR in this expanding population. Cardiovascular magnetic resonance imaging can safely be performed in patients with an implanted cardioverter, defibrillator, pacemaker, or loop recorder with adherence to a standardized protocol and established exclusion criteria, even in non-MR conditioned CIEDs. To bridge the knowledge gap and pave the way for safer and more effective patient care, a group of experts from diverse fields, including cardiology, physics, engineering, electrophysiology, and law, have come together. Their goal is to create a comprehensive guide that will inform evidence-based decision-making for patients with these implantable electronic devices. This expert consensus statement aims to address critical questions such as what are the best alternative imaging modalities for these subsets of patients. How can we ensure the safety of MR scans for patients of all ages regardless of their device type or lead configuration? What are the legal and risk management considerations? How can we optimize MRI pulse sequences to improve the image quality and diagnostic accuracy? In which clinical situations can an MR provide the most benefit for symptomatic CIED patients? By answering these questions, this statement will empower healthcare providers to make informed decisions and improve patient outcomes. The patients who may benefit from alternative modalities are those with absolute contraindications to cardiac MR. Recent implants which are less than 6 weeks, patients who do not consent for the potential risks of an MR examination, and patients who are evaluated in imaging centers with insufficient expertise to conduct a cardiac MRI in these CID patients. For many patients with cardiac implantable electronic devices, the decisions to undergo an MRI scan is a more nuanced one. While MRI is not entirely off limits, it requires careful consideration and a thorough assessment of the potential risks and benefits. Complex heart conditions, neurological disorders, cancer screening may derive significant clinical benefits from MR scans, despite the presence of a device. The decision to proceed with an MR scan for a patient with a cardiac implantable electronic device should be made on case-by-case basis, considering the specific device type, patient condition, and the potential benefits of the scans. While MRI offers invaluable diagnostic insights, it's essential to weigh these benefits against the potential risks such as device malfunction, heating of the leads, and interference with the device function. As technology advances, newer MR conditional devices are becoming increasingly prevalent, offering greater flexibility and safety. Additionally, innovative MRI techniques are being developed to minimize and maximize benefits. By working closely with experienced healthcare providers and adhering to strict safety protocols, patients with these devices can safely navigate the complexities of MRI and reap the benefits of this powerful diagnostic tool. The 3 main electronic magnetic fields used to create a magnetic resonance imaging scan include a static magnetic field, which is used to align the protons, a pulse radio frequency field to excite the nuclear spin of the proton, and a gradient magnetic field to localize in space the signal emitted after the radio frequency signal is turned off. These use a variety of different magnetic field strengths ranging from 0.2 to 9 Tesla. Excuse me. The 3 electronic magnetic waves have 3 basic effects: mechanical effects, electromagnetic effects, and thermal effects. Pacing and defibrillator components are made up of alloys, silicon, and fibropolymers. They have negligible ferromagnetic properties and hence help to make a CID MRI conditioned. This table is from Cardiac Pacing and ICD by Ellenbogen and Casella. The threat of mechanical pacemakers or ICD device movement increases with the magnetic field strength, the amount of ferromagnetic materials within the device, the distance from the bore of the MR scanner, and the stability of the device in the pocket. The device movement or rotation or vibration in an MR environment is perceived as tugging by patients. The patient should wait at least 4 to 6 weeks after the implant before an MR scan to allow sufficient time for wound healing, which leads to capsule formation and minimize tugging effects on the device. The static magnetic field currently used in routine clinical MR settings is up to 3 Tesla and shows or only negligible interference with the leads. Further experimental research proved mechanical force and torque effects under current day clinical practice in 1.5 Tesla scanners to be in the order of physiological gravity and acceleration effects. The reed switch is an electromechanical switch operated by an applied magnetic field, and in its simplest and commonest form, it consists of a pair of ferromagnetic flexible metal contacts in a sealed glass envelope. The contacts are normally open, closing when a magnetic field is present, or they may normally close and open when a magnetic field is applied. Reed switch has been replaced by Hall sensors, which is not affected in a magnetic field. The static magnetic field can activate the reed switch, leading to an asynchronous pacing and inhibition of the tachytherapies. The high electromagnetic interference can lead to power on reset when the device reverts to default factory settings. EMI can also lead to oversensing and delivery of inappropriate therapy from misinterpretation of EMI as a tachytherapy, or EMI can lead to oversensing and cause decrease in pacing, leading to bradycardia. Generators have been designed to have reduced ferromagnetic content, and reed switches have been replaced with Hall sensors, shielding with filters to reduce risk of damage to circuit and internal power supply, and a dedicated MR programming pathway to be turned on and off before and after the scan. The induced artifactual current can be interpreted as ventricular arrhythmia with subsequent attempts to initiate anti-tachytherapy arrhythmia in ICDs. However, an ICD therapy usually fails as the capacitor cannot charge due to saturation in the static magnetic field. Thus, the ICD may drain its battery while continuously attempting to charge a saturated capacitor. Then, a power on reset is a specific type of reprogramming that reverts the the device to factory default settings when battery voltage falls below a critical level or damage to the circuits is detected. This is a fail-safe feature and was seen in older devices manufactured before 2002. The settings to which the device reverts vary by manufacturer, and many devices reset to inhibition pacing with anti-tachytherapy on, where the device will initiate therapies for life-threatening arrhythmias. This is problematic when the electrical induction in the leads causes inappropriate sensing of induction as intrinsic cardiac activity and results in inhibition of required pacing. Additionally, in patients needing high intrinsic heart rates like children, the factory default may not provide the required cardiac output. However, devices are usually easy to reprogram after the MRI following a POR event. Leads have been designed to minimize heating at the tip and reduce the antenna effect in order to reduce the risk of current induction. These are achieved by altering the number of filers, which are basically winding turns of the components inside the lead. This is also reduced by altering the coating of the tip with a substance resistant to polarization and applying a heat dissipating filter at the near distal end of the lead. Increased specific absorption ratio, which is a unit, and it is associated with higher risk of thermal injury because specific absorption ratio is causes increases with the squared increase in the magnetic field strength, meaning a 3 Tesla causes a forward field increase in this unit compared to a 1.5 Tesla, provided other parameters are kept equal. Then by limiting the field strength to 1.5 Tesla, it is ensured that the patients with CIDs experience a SAR of 2 or less during the scan. However, a 3 Tesla is becoming increasingly used, and it provides better image quality, shorter scan time, better diagnostic strength, especially for neurological, extracardiological extracardiac imaging. While CID manufacturers have recently released devices that are MR conditional in 3 Tesla fields, little information exists regarding the behavior of either MR conditional or non-MR conditional CIDs during MRI performed at 3 Tesla. Currently, 3 Tesla MRI is not preferred over 1.5 Tesla. However, because the use of 3T MRI is increasing, it is expected that the experience of performing 3T MRI in patients with non-MR conditional or MR conditional CIDs will grow as well. Then this is a table in the book Cardiac Pacing and ICDs by Ellen Bogan and Carol Lee. It describes the just mentioned potential adverse effects of MRI and is worthwhile to look at. So the SCMR has given some recommendations for optimizing MR safety in patients with CIEDs. Benefits and harms communicated to the patient or the patient's guardian is utterly important. The risks of during an MR examination are additionally to those related to the underlying disease in addition to the MR scan with or without an MRI conditioned device. MRI conditional labeling is provided by the device manufacturer and relates to design features intended to reduce interaction with magnetic fields. These features include coil configuration, heat dissipating filters, non-ferromagnetic materials, and programming features. When patients with CIEDs undergo an MRI, they can be grouped into following risk categories. Category 1 is MR conditional CID systems. The generators and leads are approved for use in an MR environment. Then category 2 consists of non-MR conditional CID systems without intracardiac, abandoned or fractured or surgically placed permanent epicardial leads. And this category 2 is further classified into MR conditional CIDs, but they are utilizing intracardiac leads falling outside of the conditional requirements or nor MR conditional CID generators. Then category 3 consists of patients with any CID who also have an abandoned or fractured and these are ungrounded leads terminating in the heart, and or they have epicardial leads which were placed surgically and they were permanent epicardial leads which were surgically placed. Right. Then depending on the categories and their reimbursement, after discussing the relative risk and the clinical response required should an adverse event occur around the time of the MR's imaging, allows the patient to make an informed deduction to whether he wants to proceed in the other risk categories 2 or 3. If MRI of patients in risk category 1 is considered on label, provided that MRI follows the conditional guidance of the manufacturer. For other categories like 2 and 3, a collaboration is required between multidisciplinaries to establish a consistent patient consent procedure through which shared decision making can be accomplished, documenting informed consent. Informed consent statements and standard documentation of the procedures for MRI of CID patients should be included in the CMR report. Example wording is provided in tables 2 and 3 of the SCMR expert consensus statement for cardiovascular magnetic resonance of imaging of patients with a cardiac implantable electronic device 2024. Then this figure is from the CMR expert consensus, and it shows the recommendations for planning and performing MR scans in patients with MR conditional devices. It requires that the procedure is well planned and well coordinated and executed between the various departments. Informed consent is a must and should be obtained from all these subsets of patients. Then for monitoring purposes during the scan, MRI conditional pulse oximetry, electrocardiogram telemetry, and a blood pressure monitor should be applied during the duration of the scan. A device programmer, resuscitation cart, basic life support certified personnel, device magnet should be available on the premises. Devices should be programmed to the MRI safe mode, which consists of OVO or ODO in non-pacing dependent and VO or DO in pacing dependent patients. Tachytherapies are disabled during the MR period of MR scan. After MR scan is finished, complete device intervention is performed with restoration of the original parameters. In case of emergency MRI referrals, safety protocols should not be bypassed because performing a scan without appropriate monitoring and device management is contraindicated. If appropriate resources are unavailable, alternative imaging modalities should be ordered or patients should be referred to another facility. In patients with non-MRI condition CIDs, the procedure planning is also similar. But here an ACLS support is required to be at the hospital, and the scan is done only under a 1.5 Tesla machine. Excuse me. A cardiologist or an EP can confirm the scan conditions by confirming the MRI conditioning of the device. Scans for implants lesser than 6 weeks should be highly justified to prove that benefits outweigh the risks significantly. Device parameters should be checked and noted before and after the scan. Screening for other objects which may affect the MRI scan should be done. An MRI mode on the device should be switched on as per the manufacturer's brochure. Just a repeat of previously described points. Here the radiologist now needs to pay special attention to these specific points. Then there are certain scenarios where the MRI safety is not known in patients with mismatched cardiac implantable electronic devices, lead vendors. The CID system as a whole, even if individual components are classified as an MR conditional, may fall outside of labeling. If the patients have mismatched CID, basically pulse generator and a lead vendor. Example is like you have a lead of Medtronic and you are connecting a pulse generator of Abbott or some other company, or vice versa. Then there was a study by Bua et al. Which showed no increased risk of an MRI in patients with mismatched device lead vendors. Similar small studies have also shown some consistent similar reports. While these studies may be encouraging, it should be noted that they do not cover all potential combinations, permutations of such mismatches. Scans in patients with abandoned leads can be performed using the same safety protocols used for leads connected to generators. When the temporary epicardial pacemaker leads placed at the time of cardiac surgery are cut, needle or pin-like fragments are retained, and these are generally harmless during an MR exam, and which are performed either at 1.5 Tesla or using 3 Tesla. And are we supposed to look for these in post-cardiac surgery patients? The consensus statements have recommended against screening by questionnaire or chest X-ray for retained temporary epicardial leads. Children and adults with congenital heart disease are more likely to receive non-MR conditional CIDs because of the epicardial leads placed during the surgery. This table from the SCMR guidelines dated to 2024 summarizes expert consensus to date for MRI of pediatric patients with CIED. Epicardial leads have higher theoretical risks of lead heating than endocardial leads, and those risks are likely exacerbated by the presence of abundant or fractured leads, both of which are common long-term sequel of CIED management in this population. Even after transfer to a MR conditional system, retained or abandoned leads may add risk to a patient in the MR environment. In addition, children are smaller and pulse generators are frequently implanted in the abdomen near the ventricle mass, which increases the risks that image artifacts obscure the diagnostic yield of the CMR. However, these theoretical considerations are balanced by real world data which is available for this population, and the decision to image non-MR conditional devices should be balanced against the value of diagnostic information that can be obtained, and those risks and benefits should be communicated in writing to the family, preferably with informed consent as discussed previously. Once the scan is done, the patient should undergo a full device interrogation and a program reset to the original parameters. Tachycardia therapy should be enabled. Any change in the device parameters should be alerted to the cardiologist and the patient. If there are no changes, only one follow-up must be performed after 3 to 6 months. Otherwise, it is recommended to schedule the patient for 3 follow-ups at 1 week, 3 months and 6 months after the MRI scan. To assess for such changes, repeat CID interrogation is mandatory for all patients immediately following the MR examination, with any significant changes in device or lead parameters reviewed by an electrophysiologist. Regarding the definition of significant device parameter changes, a set of predefined conservative thresholds for significant changes attributable to MRI were developed when designing prospective studies for these conditioned devices. They were a decrease in sensed P wave amplitude of more than 50% or more, then a decrease in sensed R wave amplitude of 25% or more, increase in capture thresholds of 0.5 volts or more, absolute change in pacing lead impedance of 50 ohms or more, absolute change in high voltage lead impedance of 3 ohms or more, and a decrease in battery voltage of 0.04 volts or more. The patient then returns to their routine CID interrogation and a surveillance plan. There are newer leadless pacemakers available in market like the Micra and NanoStim by Micra is by Medtronic, NanoStim is by Abbott. Micra has retrospectively received an FDA classification of MR conditional at 1.5 Tesla and 3 Tesla. NanoStim has a CE mark approval in Europe for MR conditional labeling, but awaits an FDA approval. For 3 Tesla and above MRI scanners, the data is scarce and it will be required to provide any expert consensus statements. Optogenetics is used to modulate neuronal excitability for cardiac pacing and resynchronization. The first paper has been dated as early as 2015. These pacemakers, once available, may make MRI examinations or imaging in such patients safe. Then implantable loop recorders. Currently, no ILRs are labeled as MRI safe. They are all MRI conditioned. They are proven to pose no known hazards in an MRI environment, with the same specified conditions of use as in the case of pacemakers, and also in addition to recommended scanning conditions amongst various ILR manufacturers. It is safe even to do an imaging even up to 3 Tesla when performed with labeled conditions, although this data remains scarce. Then among with the safe MRI scan performance, obtaining an optimal quality MRI scan is equally important, and device related artifacts will be present and they cannot be predicted in advance, and the severity of the artifacts depends on multiple variables. certain artifacts like susceptibility and hyperintensity can cause difficulty in interpretation of an image, or difficulty in interpretation of a CMR image. Dealing with this is beyond the scope of this talk. In conclusion, MRI examinations in patients with CIEDs are safe when rigorous protocols are followed, regardless of the type of CIED. Categories previously considered high risk, such as abundant or epicardial leads, have shown low rates of adverse outcomes. The risk of pursuing invasive tests, delaying treatments because of misdiagnosis, or extracting non-MRI conditional leads should push referring clinicians and to support the establishment of accessible MRI programs for patients with CIEDs. Thank you.